Okay, so now let's go through the study guide questions so we can make sure we hit all the main points here. And we're going to kind of go through this quickly. First thing they ask is, why did the investigators do this study? What is the main question asked in this article? And the reason they want to know is, do benzodiazepines cause dementia, specifically Alzheimer's dementia? And so that was their question. And what study design was used in this paper? And they told us, right, in the abstract that it was a case control study. And could we have used other study designs? Of course we could have, right? We could have done a cohort study. And what would that look like? So with the cohort study, we would have two groups here. We would have one that is taking benzodiazepines and one that is not taking benzodiazepines. And we see how many get Alzheimer's in both of these groups, and then we compare them and we say, okay, are they about the same or not? Do we think that these are from the same group or not from the same group by looking at either p-values or, better yet, confidence intervals? Or we could have done a randomized controlled trial where we took people and we randomly assigned them to take benzodiazepines or not take benzodiazepines and see how many get Alzheimer's disease. So why did they use the case control? Well, number one, it's cheaper. Number two, it takes less time to complete. And number three, it's easier for rare diseases to do this. Because maybe the incidence of getting Alzheimer's in this group is so small. It is more than the ones in this group, but it's so small that we would have to have such a huge population here in order to find it. And that would be very expensive. And for randomized controlled trials, maybe it's not ethical to force someone to take benzodiazepines, especially if we think it's going to cause them harm later. And so that's why we couldn't do a randomized control trial. The next question asks, how was the outcome assessed? And so remember, I put the case control up here as well. We start with the outcome and we move to the exposure in the case control, whereas in this one we'll go in the other direction in the cohort trial. We start with the exposure and we measure the outcome. It's the same with the randomized control trial. We start with the exposure and we move to the outcome. So the outcome here is who has Alzheimer's disease. And the way that they decided this was they looked at ICD-9 codes. So these are diagnostic codes that are used for billing, but we use them everywhere, so it's an easy way to find this data. Does it mean that this patient met all the clinical criteria, the gold standard diagnosis of Alzheimer's disease, like neuropsychological testing or findings on neuropathology? No, it just means that somebody decided to put in that code at some point because they thought the person had Alzheimer's. So is it perfect? No, absolutely not. Is it available and useful? Yeah, I guess so. Is it possible that somebody was misclassified? Certainly is possible, right? Maybe somebody did not know there is a specific way to diagnose Alzheimer's and they just guessed, and now that is put into the ICD-9 code, so we count that as Alzheimer's. And so this is called misclassification bias, where somebody is improperly put into the wrong group. And that's counted as a non-differential or random bias, because you can just as easily be put in the not Alzheimer's group and you do have Alzheimer's as you can be put in the Alzheimer's groups when you don't. So what this tends to do is it tends to bias results, but it biases it towards there's not going to be any difference, because some of the people who actually had Alzheimer's are in this group and some of the people who don't have Alzheimer's are in this group, and so it's going to make everything kind of mixed together, and when everything mixes together you lose the difference between the two groups. So misclassification bias is random, it's non-differential, it doesn't push toward one particular direction, it just mixes everything up, and so it biases towards there being no effect of this drug causing Alzheimer's. That's one of our little star points that we want to make sure that you get in this video. Okay, the next question says, is there evidence of selection bias? So we're going to be talking about another kind of bias here. Selection bias is if the controls and the cases were selected from two different groups. So maybe this group of patients who has Alzheimer's disease was taken from a population of psychiatric patients, and the controls were taken from a group of patients from a general internal medicine clinic, and so they don't have a psychiatrist. And maybe the psychiatrist is less likely to give the benzodiazepines because they're already worried about this association, whereas the Alzheimer's or the general internal medicine people might not be aware of it and say, and are more likely to give it. And so that would mean that they would not be, coming from the same group, and there may be different, confounders in there from that. So, is there evidence of selection bias? It's possible. But I don't think they mentioned that they came from any particular clinics. I don't think they gave us any selection bias in this article. But that's another thing you want to know about is selection bias, is where they selected from different groups, and of those two different groups, would there be a reason that one would get more or less benzodiazepines for some reason or the other? And this bias might actually push you more towards one than the other. So this one would be a differential bias. Okay, and so it differs from the misclassification one, which was a non-differential one. And look at that. That's our next question, actually. What is misclassification bias, and how does it differ from selection bias? And we just talked about that. Misclassification bias is when one group gets labeled wrong. And selection bias is that the two groups are not coming from similar populations, they are different in other ways other than just the benzodiazepine use. Next question asks, how were the groups matched, and why were these matching factors selected? So remember, for every Alzheimer's patient that they found, they tried to find 4 other people that were of the same age, the same gender, and had the same duration of follow-up. And they matched on these because we know that people, age and gender are known risk factors for Alzheimer's disease, and duration of follow-up, because that might, differences in the timeline of exposure for benzodiazepines might account for differences in total benzodiazepine exposure, meaning if we didn't follow some groups as far back, we might not have caught all the benzodiazepine use that they got. So we want to make sure that we follow them all the same way back. So the next question is, why 4 controls for every case? And let's go to the next page, and you can see here that we talk about the case control quotient, and power. So it looks like the more controls we have per case, the more power we have. So if we had 1-to-1, we might have 90% power. If we had 2-to-1, we'd have like 92.5. 3-to-1 looks like 96, and then 4-to-1 maybe got us to 97.5% power. So the reason we do this is to increase power. The next question asks, were there any confounding variables? And we were looking at table 2. And if you'll remember, let's actually take a look at that table again. So I copied it here. And remember, we looked for any p-value that was greater than 0.05 or 5%. And we did find some, right? There was this one. There was this one. Sorry, I take that back. We were looking for p-values that were less than 0.05, right? Because that means the two groups are different. And so we did find some, right? We found this one, and there was one other one, right? This one here. And we looked to see what that was, and that was myocardial infarction, hypercholesterolemia, and anxiety. So these could be potential confounders here, right? Because they are associated here with the outcome, which is the two groups that we have, as well as the exposure, because the exposure is coming from those same two groups, so we can't say. So they're potential confounders. And you can see stroke here was pretty close to 0.05. The next question asks, were there clearly defined groups of patients similar in important ways other than dementia? And do the similar differences affect the validity of the study? And we just looked at that, right? We said that there were more myocardial infarctions in one group. There was marginally more stroke, right? It was 0.06 more hypercholesterolemia, high cholesterol in another group, and anxiety as well. And the anxiety one is the one that's important, because anxiety could be a reason why somebody was taking benzodiazepines in the first place, right? So that's a problem. And that's one of the problems with observational studies, is we cannot really control for all of these things. And so there's always going to be these confounders here. The next question asks, what are other risk factors for Alzheimer's disease, and are they also related to benzodiazepine use? So social socioeconomic status is a risk factor for Alzheimer's disease, and it certainly is possible that individuals of lower socioeconomic status might get more benzodiazepines. Smoking is another risk factor, right? And I don't know that smokers are more likely to use cigarettes, or benzodiazepine users are more likely to smoke. So possible, but I don't know how so. Exercise was another one. So low levels of exercise are associated with Alzheimer's disease, and maybe people who don't exercise as much are prone to depression and anxiety, and so maybe they get more benzodiazepines. What about social activity was another one? And it's certainly possible that people with less social support, with a weaker social support network, are going to be prescribed benzodiazepines at a higher rate. Alcohol use is another one. And again, actually, this one, moderate alcohol use may be protective against Alzheimer's disease. And people who drink maybe are more likely to take benzodiazepines. Now, of course, more severe, high levels of alcohol consumption are going to be associated with a cognitive decline, but that's not necessarily Alzheimer's dementia. And then the last one is the use of other medications. And many medications can affect cognition, and it's certainly possible that they would also be using benzodiazepines as well. All right, the next question asks, well, why was a follow-up of study patients complete and long enough? So why did they go for 5 years, and why did they perform another analysis, this sensitivity analysis, to look at 6 years of retrospective data? So the investigators did 5 years because they figured that benzodiazepines that were initiated more than 5 years ago we were probably not treating the early signs of Alzheimer's dementia with benzodiazepines, right? We could have certainly been fooled. We saw early Alzheimer's. We thought they were anxious, so we gave them benzodiazepines. Then they developed full-on Alzheimer's, and we could blame the benzodiazepines on the Alzheimer's, but it was actually the other way around. We gave them benzodiazepines because we mistook the early Alzheimer's. So they figured 5 years was enough time in between to have gotten rid of that effect. And then this 6th year that they did, so what they did was, they first looked at their data over 5 years, and then they did another 6th year, and they wanted to say, did this extra year change anything? Did it affect the data in any way? And it didn't. And so that meant that, 5 years was probably long enough. We looked another year to see if that one made a difference. Like let's say we did 1 year, and then we looked at 2 years, and we see a difference there. And we say, okay, well, maybe 1 year was not enough, because we may have been treating those prodromal symptoms at this point. But at 5 years, we might ask, is 5 years really long enough? Maybe there's a difference there. Maybe we could have done 6 years and see if it made a difference. I mean, you could really extend this out to 20 years, right? But there was no difference between 5 and 6. There's probably not going to be a difference between 5 and 20. So let's move to the next question here. Is there an increased odds of developing Alzheimer's disease in individuals receiving a benzodiazepine as compared with those who do not receive a prescription for benzodiazepines? And we ask some sub-questions here. Does it change when adjusting for confounding variables, dosage, or half-life? So we need to look at that table again. So I put the table here, all right? And first, let's cross out anything that we know is not statistically significant because the confidence interval crosses 1. And I think that's it. So I did cover up the question, but the question said something like, does the risk change when we adjust for confounding variables? And that's what happens here and here, right, in these models. So we started with an odds ratio of 1.52. When we use model 1, which looked adjusted for high blood pressure, myocardial infarction, stroke, platelet inhibitors, oral anticoagulants, etc., 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 it went to 1.51. And then when we adjusted again for the things in Model 2, which is anxiety, depression, and insomnia, it did decrease some, but it still remains statistically significant, right? Because these confidence intervals are all significantly above 1, right? Okay, then the next question was it affected by benzodiazepine dosage? And so here is our dosage right here. And so if we were to say this is no dosage, let's just call it mild, medium, and high dosage. Did anything happen with that? Yeah, absolutely, right? It went from 0.08 here, right? And then it went up to 1.33 and then 1.85. So it went up with increasing dose. And with the different models, that same thing persisted, right? And so, yes, with increasing dose, we had increasing effect. And then the last question was, is the risk impacted by benzodiazepine half-life? And so that we know we looked at the bottom here. And so we have short half-life and long half-life. And while it does look like there's a difference here in these different models, if you look at the confidence intervals, you can see 1.27 and 1.61 overlaps with 1.48 to 1.99, right? So it is certainly possible that if you have something that goes from 1.27 all the way to 1.61 and something that is 1.48 all the way to 1.99, that you could have a value that is somewhere in this middle section here where it's the exact same thing. So we cannot say that the half-life made a difference, even though it looks like the odds ratio, the estimate here is increasing, the confidence intervals are overlapping, so we cannot really say that. Okay, let's look at the next question. Do the results satisfy diagnostic tests for causation? And these are the Bradford-Hill criteria. Again, this is an important thing, right? And so we talked about before that these observational studies do not test for causation, right? They can only say association. And so you can strengthen your argument, though, by doing some of these other tests. And this is exactly what happened when we were looking at does smoking cause cancer. I think it was Bradford Hill and some other dude who said that the more cigarettes you smoke, the greater cancer you had. The amount of cancer of the people who smoked was way more than the other, right? And so then all these tests for causation kind of built up a pretty strong argument. Even though it was from an observational study and technically does not establish causation, there was a lot of evidence that helped us make that conclusion. So let's look at each one of these. Strength. So this means that there is an association, that there's higher effect in the group that is exposed versus not exposed. And we can see here that is indeed the case, right? It was 1.52 here is the effect that we had. So yeah, I think that there is a strength, higher strength. Consistency. Consistency means that other tests and other papers also showed similar results. Like if some papers showed no effect and some papers showed there is some association, you say, I don't know. But there were 5 other studies. We didn't read them, but there are 5 other studies that did show an effect. And I think there was a 7th one that maybe showed a protective effect of benzodiazepines. So consistency, we kind of have it. We have 6 showing that the benzodiazepines maybe are associated with dementia, Alzheimer's dementia, and that 7th one maybe not. Temporality, and this one means that cause precedes effect. So benzos came first, and then you got the Alzheimer's. We have that. Dose response curve, meaning the more benzos you took, the stronger the effect, and we did see that, right? We saw that here with our 1 to 90 days, 91 to 180, and 180, greater than 180 days. The longer time benzos that we took it, the stronger the effect of getting Alzheimer's dementia was. Plausibility, does it make sense? Is there some sort of biologic mechanism that can explain this? And yeah, there is. Benzos have been associated with amnesia, cognitive impairment, paradoxical agitation, and all sorts of other behavioral abnormalities. And so, it certainly is possible. It's plausible. And the final one is experimental evidence. Did we get a randomized controlled trial or something like that? And we don't have one. No randomized controlled trial, so we don't have this evidence. But we do have a bunch of evidence there that is there. So maybe we have a stronger argument for causation than we initially thought, right? Because this is a study that can show association, but not causation. But the more these Bradford-Hill criteria we meet, the stronger an argument we can make that maybe the benzos actually cause Alzheimer's dementia. Now the rest of these questions I'm not going to do today. This is if you are applying this to actually patient care, like you have an actual patient in whom you are thinking of giving benzodiazepines to and you're worried about Alzheimer's dementia. Would this study help you with that? And since we don't have that, you could say, were the study subjects similar to patients in the case listed above? So let's say we had a 16-year-old we wanted to give benzos to. We were looking at, I think, over a 66-year-old or something like that. So we would say no. But if it was an 82-year-old, then yes, certainly. Should benzodiazepines be prescribed to the patient? And what alternative treatments are available? Again, this is your judgment call. Do you want to give benzodiazepines to this person, knowing that there is this association with a lot of Bradford Hill criteria there, strengthening the argument for causation? You'd have to weigh the benefits and against the costs. Maybe this person can be calmed down with benzodiazepines, and that's why you need to give it, or maybe it's for seizures, and that's the only medicine that's working. I don't know. So you have to look at all of those different things. Are there other medications that are available? Maybe it's for insomnia, and you want to give a different kind of medicine, like melatonin, maybe, to help them sleep. And you got to also talk to the patient and ask them, what does the patient think? Do you want to take this medication, given these risks? Maybe the patient has a history of Alzheimer's in their family, and they're really afraid of it, and so they say, no, I'd rather have the anxiety that I'm suffering from, or whatever reason we were considering giving benzodiazepines. Okay, that is this paper. So in review, you want to know what a case-control study is and how it differs from cohort studies and randomized controlled trials. You want to know what misclassification bias is, and that's when one group is misclassified. It's non-differential bias as opposed to the selection bias, which might be differential. We want to know how to determine which ones are potential confounders in here and we do that by looking at these p-values. You should be able to read a table and kind of get the idea of what's going on in there. And you're just looking for trends and numbers. 1.52 versus 1.51. It doesn't matter as much as you know that this is significant and this is greater than this and that's greater than this, but the confidence intervals here may overlap, right? And you're looking at those sorts of things here. And you're also looking at what is this table saying? And I think that's probably one of the more important things, is you need to be able to read a table. That's something they may give you on boards, is a table that you need to read. So if you do nothing else for this paper, at least look at the tables and try to understand for yourself what is being said here and what does that mean. And when you read a paper after having read the tables, it's a lot easier than reading something where someone is writing about all the numbers and the explanations, because I find that very difficult to understand without actually seeing the numbers first. Okay, if you have any questions, please feel free to email me, any of your EBM instructors, or Dr. Shakur, or anyone. And that's it. Okay, thank you very much for watching. Go Rams.